Alright, so your core concepts here are going to be able to describe the A&P of the hematologic system, understand what happens with sickle cell, vaso-occlusive crisis, understand your different types of anemias, describe some of the diseases that are going to affect your white blood cells, and understand how disease processes affect your coagulation. Right, so hematology is just a study of blood and blood forming or hemopoietic organs and tissues, and the disorders that are related to your red blood cells, white blood cells, platelets, and coagulation. Now, these organs are going to make blood, and it starts with the most basic blood cell, which is a stem cell. And the end product here is going to be a mature white blood cell, which works with our immune system, a mature red blood cell that's going to carry oxygen and waste products, and platelets, which are going to help with clotting after an injury. Now, plasma is what's going to transport your blood, and it is about 55% of your blood volume, and it's 92% of water, essentially. So a good bit of your water is in plasma. It also has the formed elements with your erythrocytes, or red blood cells, your leukocytes, that are your white blood cells, and your thrombocytes, which are your platelets. All right. As far as the average liters of blood, average adult, somewhere about 5 liters or so, and this depends on how big you are, because the bigger you are, the more blood you will typically have. Your body will produce more. You also have more veins and arteries. The smaller you are, the less you'll have. With your liver, your spleen, and your bone marrow, these are going to help eliminate your old or damaged blood cells, help break them down and turn them into something else that your body can use. Your kidneys are going to secrete your hormone erythropoietin that stimulates your blood cells. This is why people who have kidney failure are prone to anemias. Now with this, when you have hypoxia, it's going to trigger the release of erythropoietin in the kidneys. And what this is going to do is it's going to increase the division of the stem cells in the bone marrow, which are then going to mature into your red blood cells. When they mature faster, you've got increased numbers of circulating red blood cells, which helps transport oxygen and remove waste products faster. So it's just a feedback system. Your plasma is going to carry proteins, your albumin, clotting factors, your antibodies, all these things that they test for if they're doing blood transfusions. It's also going to carry electrolytes and nutrients. Some carbon dioxide is actually dissolved in plasma. So there are lots of different things that come through this channel here. Now with your red blood or your blood cells, you've got your erythrocytes, your leukocytes, and your platelets there. Your leukocytes, last anywhere from days to years. Your platelets are going to last days, and your red blood cells actually last the longest, usually on average 80 to 120 days. Now your red blood cells are flattened disc, and they've got kind of a thicker edge. Think almost like a lifesaver, but if the middle was filled up and just a little thinner there in the middle. And what this does is it's going to give surface area for that gas exchange, for that oxygen carbon dioxide, and it makes them flexible so they can squeeze through those 1 cell thick capillaries. It's made from the stem cells in the bone marrow, and they only live for up to about 120 days. Now when we're looking at red blood cells, a lot of times when we're talking lab values, they will talk about H&H, or hematocrit and hemoglobin. So hematocrit is the measure of percentage of blood volume that is formed elements. So if this is low, then that means we don't have enough of our blood cells. Hemoglobin is the protein that actually binds to the red blood cell that carries the oxygen and the carbon dioxide within the red blood cells. So if it does not have enough hemoglobin, we don't have enough oxygen and carbon dioxide carrying capabilities. Our white blood cells are also produced in the bone marrow, and these are signaled by your messengers that go to wherever in the body they're needed. So if there's signs of injury or illness or something like that. You've got several different types: neutrophils, eosinophils, basophils, monocytes. They respond to different types of antigens, different problems. So most of them are going to be specific to specific things. All right, our antibodies are what we acquire through the immune processes after either initial exposure to a pathogen or artificial exposure, some sort of exposure to a pathogen. They are kind of our first response within the body that goes out and starts fighting the inflammation or infection. Now our platelets are just pieces of thrombocytes, and these get activated when you have collagen, tissue collagen, in the injured blood vessels. These platelets get sticky and they adhere to each other, and they adhere to the tissue, and it creates a plug. And then this plug goes through the coagulation cascade, or the clotting cascade, And what happens is you've got the damage, then the platelets start sticking together, and then you've got this chemical pathway that happens where you've got prothrombin that's going to activate prothrombin and convert it to thrombin, and then you've got thrombin that's going to activate with fibrinogen and convert it into a stable fibrin clot. And then that'll stay a stable fibrin clot until it's no longer needed, and then it will actually get broken down. All right. Now, aspirin, one of the drugs that you will give for chest pain, which is suggestive of a MI, we give this to inhibit that platelet aggregation. So it doesn't break down a clot if it's already there, but it's going to kind of stop them from getting stickier and binding together, which will hopefully reduce the clot from getting bigger. Now, as far as bleeding, hemorrhage, of course, is bleeding. Hemostasis is just the process of stopping the bleeding. So these injured blood vessels are going to constrict to slow that blood flow of blood through it. And the platelets are attracted to that area, form that plug, and hopefully coagulate and stop the bleeding. Now, sometimes this process can actually hurt you in certain circumstances when you've got a massive injury or massive injuries. You can have the systemic formation of your blood clots. And then basically what happens, you form all these little blood clots and you use up all of your clotting factors, and then you start bleeding from everywhere. So it's like a damned if you do, damned if you don't. But that's called your disseminated intravascular coagulation, or DIC. Right. There are a bunch of drugs that can either indicate some kind of clotting or hematologic disorder, or that can cause symptoms of it, like alfalfa, which is used as a tea for inflammation and arthritis. It actually contains vitamin K and coumarin, which can interfere with anticoagulants. If somebody takes aspirin a lot or takes an aspirin every day, they may have increased bleeding due to that platelet inhibition of the aggregation. Prescription medications, Plavix, Lovenox, things like that. These are different medications that will inhibit your bleeding in some form or another. Garlic can cause increased bleeding if taken in conjunction with your warfarin. It decreases your platelet aggregation. You'd think that vampires would like a little bit more than, since it would increase your bleeding. But anyhow, NSAIDs, a whole lot of different things there. Ginger can cause decreased platelet aggregation, which can increase your bleeding. Just some of the things with your bleeding precautions, aspirin, needle sticks. You'll be careful. These patients are taking anything that's going to cause increased bleeding, where you're going to be very careful with your needles, because the more that you stick them, the harder it is going to be for them to clot and slow the bleeding once the stick is over. Now, looking at your blood groups, you've got several different types of blood groups, and what these do are determine compatibility. All right, so it's determined by your blood groups, your A, B, and O, your A, B, B, and then O. And you also have the Rh factor antigen. So type O has no antigens present, so it cannot get A or B or AB blood, because it sees those antigens and says attack, and it thinks it's going to go attack it because it doesn't recognize it. Now, A can get A blood or O blood, because O blood doesn't have any antigens for A to recognize. Now, it cannot get B blood because B blood has those antigens and it's going to go attack it. Right, so your universal donor is going to be an O negative, and your universal recipient is going to be AB positive. But AB positive can only give to AB positives because they've got all the antigens, it seems like. All right, as far as the positive and negative, that's just another antigen on the red blood cells. Where this really comes into play, besides just transfusion reactions and things, is if you have a woman who's pregnant, and she is Rh negative, they don't have that Rh antigen. So if they're exposed to Rh positive blood, they could develop anti-Rh antibodies, which could cause a hemolytic disease of the newborn and potentially cause complications for the mother as well. Now, blood count is typical as your CBCs, just your complete blood count, and this measures your hemoglobin, different types of blood cells, white blood cells, platelets, things like that. So if you hear somebody talking about this, they may be under treatment for cancer or something of that nature. What we really want to be careful here is take every precaution with a patient who is dealing with this, because not so much that they'll hurt us, but because we could hurt them. A common virus that may do nothing to us could take them out and kill them. All right. Some patients may not be aware of any underlying diseases or hematologic problems. They may just think they bruise easy, or they may have, just a little bit of easy bleeding or something like that. Epistaxis is another common problem, and that's where you just have an excessive nosebleed. Could be from high blood pressure, could be from injury. There's a lot of different things. Could be just from easy bleeding. All right. Purpura, this is kind of that splotchy, blotchy looking, almost like a bruising hemorrhage under the skin. And so what this is just where the little blood vessels have actually ruptured. And so there are some of these illnesses that will cause it to be more likely to happen. It also can happen like if somebody's got allergies or something, they scratch, they can actually damage the underlying capillaries and cause this rash type looking thing as well. All right. Now that is different from your petechia. These petechia are tiny little bruises in a rash pattern. We're splitting frog hairs here, but you see how it's more individual spots, whereas your purpura is more splotchy in big areas. All right, so petechia is little tiny spots. You'll hear talk about if you ever watch crime shows, like petechia in the eye, pinpoint hemorrhaging in the eyes. That's what they're talking about there. Alright, so your general management here. Look for any hemorrhage, control any hemorrhage. Look for other signs, purpura, petechia, anything like that may show that they're not having abnormal bleeding. Pain management as needed, oxygen fluid replacement as needed. Some of your signs and symptoms, now to be fair, a lot of these could go with just about anything else as well. Tachycardia, tachypnea, dyspnea, fatigue, pallor, fever, hematuria. All those things you can see in other stuff too, right? So this is where that really good history taking and questioning comes into play. All right, get your baseline vitals, use any monitoring devices as appropriate. Find out what kind of medications they're taking as well. Now, some specific things. Transfusion reactions. All right, so as an advanced, you're not going to be giving blood. As a paramedic, you might, depending on where you are. But what you may actually do is transport somebody who has blood hanging as a transport out of a hospital to another hospital. Usually with your transfusion reactions, they're going to happen within those first 10 to 15 minutes or so. So you're probably not going to see them. But if you do, there are 3 different types of allergic or transfusion reactions. So the first one is allergic reaction. This will present much like an allergic reaction. They'll have facial flushing, hives, rash, and itching, terrible itching. Right? For febrile, they'll spike a fever. They'll have chills, anxiety, tachypnea, tachycardia, and headaches. And then the worst one, the hemolytic, they'll have all of the same as the febrile, plus they'll have some back pain, and then the blood pressure will start to drop, and what's happening is their blood cells are breaking down. All right, with all of these reactions, we are going to stop the blood products. We're going to maintain a line with normal saline, and if it's an allergic reaction type, we're going to treat similarly to a allergic reaction. Now, some red blood cell disorders. So the first and foremost, anemia. Anemia just means you have an abnormally low hematocrit, and you become symptomatic when the hematocrit drops below 30%. This could be due to a decreased production of red blood cells. It could be increased destruction of red blood cells. It could be loss of red blood cells due to hemorrhage, or it could be, any number of things. Regardless of why we have an anemia, though, the cells are not getting enough oxygen for energy production, which means we are not maintaining homeostasis. Now, your signs and symptoms: fatigue, pallor, tachypnea, tachycardia, shortness of breath. They may have chest pain or something else like that, okay? So the different causes of anemia, there's several different ones. You've got hypochromic, which is just a iron or vitamin deficiency. You may have a pernicious anemia, and this is where you have a low levels of B12. You may have erythroblastosis, and this is where your antibodies are destroying your red blood cells. You may have a secondary anemia, like bleeding, leukemia, cancer, chronic kidney disease, whatever reason you don't have enough red blood cells. You may have increased red blood cell destruction due to sickle cell or an enzyme deficiency, or you could have what they call aplastic anemia, where your bone marrow is malfunctioning and not producing red blood cells as it is supposed to. Now with your sickle cell anemia, in the pre-hospital setting, this is the one that you're probably going to deal with the most. And what happens is you get a whole bunch of red blood cells. It's a hereditary disease, but these red blood cells are funky shaped. They're shaped like a sickle. And when they're shaped like a sickle, they don't move properly. They don't slide past each other, so they start to clump up. And when they clump up, they get stuck in smaller areas like your hands, your joints, things like that. And they cause really bad pain. They can also cause decreased perfusion to that area that's affected as well. When these little clumps of your sickle cells obstruct the whole capillary beds, this is called a vaso-occlusive crisis. And this is usually, it's going to depend on, each person's a little different, so the intensity will vary, but usually it's going to be very, very, very painful, and it requires some sort of analgesia. In the pre-hospital setting, we're looking at oxygen and hydration. Now your white blood cell disorders, you've got leukemia, and this is where you have a cancer that causes bone marrow to rapidly produce large numbers of abnormal white blood cells, and these are going to crowd out your normal cells, which leads to anemias, bleeding, and high risks of infection. Your lymphomas are cancers of your lymphocytes. You've got B and T lymphocytes, and this is usually going to be localized to the lymph nodes, and you may have Hodgkin's or non-Hodgkin's. Survival rate for Hodgkin's, pretty good. Decently okay for non-Hodgkin's. Alright, usually have a history of your profuse abnormal night sweats, and with that, seen in either lymphomas or your TB infections. Your multiple myeloma is a cancer of the cells in the bone marrow, and these abnormal cells multiply, which crowds out your normal cells, which means you're not producing your blood cells like you're supposed to. You also tend to have pathological fractures of that affected bone, where it will just break on its own. Now, your platelet disorders. If you have a low number of platelets, it's considered to be thrombocytopenia. And what happens is these platelets can be reduced in number or impaired by your leukemias or your bone marrow disorders. When you have decreased platelets, you're not going to clot as well. All right, you're going to have increased bleeding, and if you have increased platelet counts, then you have increased clotting, which means you're more prone to things that are clot driven, like MIs, strokes, PEs, that kind of stuff. Now, hemophilia is an inherited disease, and you have deficiencies in some of the clotting factors. There's several different clotting factors, and what type of hemophilia you have depends on what clotting factor you're missing. It can cause painful swollen joints, abnormal menstrual cycle bleeding, bleeding gums, epistaxis, GI stuff, whole lot of things. So the treatment is to replace that specific clotting factor. They actually have some auto-injector type things or injections that they can do of these clotting factors. Now, your blood clots and your DVTs, your deep vein thrombosis, this is where you get your blood clots that form in the large veins, usually in the legs, pelvis, and arms. If it breaks loose, it can become a pulmonary embolism or potentially even an MI or a stroke. All right. Things that can lead those up to making more common: trauma, hormones, traffic accidents, operations, blood disorders, other immobilization, things like that. All right, what you'll see is if it's like in a leg, you'll see some swelling and pain, warmth and redness on that affected leg, and maybe fatigue of that leg as well. Now, your DCI, or DIC, your disseminated intravascular coagulation. We briefly touched on this earlier, but this is that overactivation of the clotting mechanisms. Could be from sepsis or surgery or severe trauma, but what happens is the clotting factors are administered. All these clotting factors come into play, and then you get all these little clots, and then you run out of clotting factors. And so then any further bleeding can't be stopped. So then you start having a patient who's bleeding from multiple sites. So they're increased clotting and bleeding out at the same time. Right, so hematology, study the blood and blood-forming organs. The blood is made up of your plasma and formed elements. Plasma holds your proteins, antibodies, clotting factors, electrolytes, nutrients. Red blood cells carry oxygen and carbon dioxide. Increase in white blood cells as a result of your response to infection, inflammation, or pathological process. Got a bunch of different types of white blood cells that all have specific functions. Your platelets are going to help with clotting. Done.